Hello, welcome to Cardio Flash College, a place to learn cardiology with flash animations. Today we continue with our weekly section Flash Code, a place to explore the world of acute coronary syndromes and primary angioplasties. Let's begin. This week we have a male of 76 years, smoker, with a background of arterial hypertension, dyslipidemia and chronic ischemic heart disease that manifested as a myocardial infarction in 2006 and was treated percutaneously in another healthcare facility without any clinical report currently available. He is diagnosed at the emergency department of an inferior ST segment elevation myocardial infarction of 4 hours of evolution. When he arrives at our unit, the patient is stable, but chest pain perseveres. This is the electrocardiogram of our patient. As you can see, it is evident the existence of changes on the ventricular repolarization. These alterations express as elevations or descents of the ST segment in some leads, and they suggest an acute myocardial lesion. Could you identify these disturbances? That's it! In this electrocardiogram, we can see that there are Q waves and the elevation of the ST segment in the inferior leads, more evident in the lead 3 regarding the lead 2. Moreover, it is relevant to point out that there is an image mirror descent in lateral leads 1 and AVL. But what clinical relevance does this have? Very simple. ST segment elevation myocardial infarction is the regular clinical manifestation of a complete blockage of a coronary artery and constitutes a cardiological emergency where every second counts. In this way, our main objective is to open the artery as soon as possible, whether it is using fibrinolysis or primary angioplasty. In this case, cardiac catheterization was performed, and, as you can see, there is a diffuse theromatosis of the left coronary bed. We can appreciate in this projection that there are a non-significant lesion in the distal coronary trunk and a severe lesion of the ostium of the second marginal branch. Although we cannot see the total territory of the anterior descending artery, it is evident that this artery has been previously treated with stents. Let's take a look at another projection. In this projection, we can assure that the anterior descending artery is permeable, with non-significant diffuse theromatosis of the entire vessel and without restenosis of the previously implanted stent. On its own hand, although it has severe lesions in different segments, the diagonal branch is open too, and it does not seem responsible of this infarction. Thus, recalling that the electrocardiographical alterations consisted in an inferior elevation of the ST segment, more pronounced in the lead 3 rather than the lead 2, and with an image mirror descent of the ST in lateral leads, it is easy to imagine that the occluded artery is the right coronary artery or one of its branches. Let's take a look at this vessel. This is the first projection that is performed and, as you can see, the right coronary artery is open and it does not present significant lesions. Let us change the projection and take a look at one of the distal bifurcation branches. These are the right marginal artery and the posterior descending artery. Although there is a severe stenosis in the distal segment of the posterior interventricular artery, it is clear that both arteries are open and they do not seem responsible of this infarction. This is why, before the existing obstacle, this means on one hand the patient has pain and an elevation of the inferior ST segment, and on the other hand the right coronary artery and its branches, just like the circumflex, contrary of what one would expect, they are not closed and the majority does not present significant lesions. A rapid echocardiogram was performed to obtain complementary information. This is the parasternal long axis view at the papillary muscles level. As you can see, there is a clear akinesia of the inferior wall that is also evident in the apical two chambers view. This can only suggest that there is a closed right coronary artery branch that has not been located yet. This is why modified angiographical projections on the right coronary artery were performed and, although no arterial stump appeared, a key finding came into view. Do you see it? It is right there, right next to the coronary artery. That's it. It is an old coronary stent, probably implanted in 2006 in a marginal acute artery that, although we cannot see it, we know it is there. Now that we know where the obstruction is, treating it is the only thing left. First, we will have to pass an angioplasty guide wire through the closure. Sometimes passing the guide wire partially opens the artery and allows us to see the distal bed. However, this is not the case. In this case, next we predilated the lesion and then implanted an adjusted stent to the ostium of the previously obstructed branch. This props the artery and restitutes the blood flow. After post-dilating proximally the new stent, an angiographical control is performed. And this is the final result. As you can see, we have recovered the blood flow of the artery after implanting the stent, obtaining a good angiographic outcome and without pre-procedure complications. In this way, with the artery open, the ST alterations are progressively improving and pain disappears, being this emergency resolved, and with it, our chapter. It has been all for today in Cardio Flash College. We hope you liked the video. If so, subscribe to the channel and leave a like. We'll see you in the next class. And remember, don't come late. Bye!